Hello everyone. So let us study today about Rh negative pregnancy. This is Dr. TSR. Kindly subscribe to my channel for more videos. Right? So why are we so more worried about Rh negative is because it causes fetal anemia. So when it is fetal anemia or hydrops fetalis, it can be immune related or it can be non-immune. So immune is mainly because of Rh negative, where there is antibody formation against the fetal Rh antigen, right? So when it comes with the non-immune, so what are the non-immune causes of fetal anemia are, so the things, infections such as TARCH are the most common is parvovirus B19, or hemoglobinopathies such as thalassemia, or enzyme deficiency like G6PD deficiency, or pyruvate kinase deficiency, or glucose storage disorders, or hereditary spherocytosis and Fanconi anemia, or any disorders like fetal-maternal hemorrhages like such as vasa previa. Okay, so vasa previa, Fanconi anemia, glucose storage disorders, and then comes pyruvate kinase deficiency. So these are some of the causes of non-human hydrops fetalis. Okay, that is the causes of fetal anemia. Okay, so now coming to today, let us mainly focus on Rh antigen. Rh antigen is present in chromosome number 1, right? So Rh antigen mainly the D antigen. If D is present, that is Rh positive. If D is absent, that is Rh negative. So what to do when mother comes as Rh negative pregnancy, right? So first is do the blood group. So this is where I am going to write the flow chart. Kindly take a note on this. So confirm the blood group, that is again it is Rh negative. When it is Rh negative, confirm the husband blood group. So husband blood group, if it is positive, then only we are going to follow up the mother. So when it is Rh positive husband, Rh negative mother, do ICT at 12 week itself. ICT at 12 weeks. It can be either positive or it can be negative. So usually in first trimester without prior exposure, ICT will be negative. If ICT is negative, repeat again at 28 weeks. Again at 28 weeks, ICT can be negative or it can be positive. If it is negative, you give routine antenatal anti-D prophylaxis at 28 weeks. Even if you give antenatal prophylaxis, you are supposed to give postnatal prophylaxis also. So if it is positive, we will go ahead with the positive algorithm. If Rh ICT indirect cum test is positive, then you look for ICT titer. Okay. So the ICT titer can be less than 1 in 16 or it can be more than 1 in 16. If the titer is less than 1 in 16, you do repeat the titer monthly. You repeat the titer monthly, and if it is less than 1:16, you are not worried. If it is more than 1:16, that means there is anemia. So you will go ahead with middle cerebral artery peak systolic velocity. It can be less than 1.5 multiple of meridian, or it can be more than 1.5 multiple of meridian, more than or equal to. Less than 1.5 means there is no fetal anemia. Here you are going to repeat MCA Doppler every 2 weekly. Okay, but you are not going to repeat the titer again. You already know titer is positive, so you repeat MCA Doppler every 2 weekly. If it is more than 1.5 multiple of meridian, that means there is shunting of the blood towards the cerebral vein, there is vasodilatation, there is increased blood speed. So that means there is severe anemia. So here you will do cardosynthesis. You will do cardosynthesis and look for what is the fetal hematocrit. If the fetal hematocrit, coming to the next category, if the fetal hematocrit is less than 30%, that means there is severe anemia. If it is less than 15%, that means there is fetal hydrops. If it is more than 30%, you will do weekly MCA Doppler again. You will do weekly MCA. If MCA is abnormal, you will go ahead with weekly hematocrit. Okay, if it is less than 30%, we'll go ahead with intrauterine transfusion, and details about intrauterine transfusion is already uploaded in the channel. Please go to that video. So we'll do via the umbilical vein catheter. It is O negative, cytomegalovirus negative, hematocrit of 80% and leukocyte depleted, irradiated. So your aim is to achieve the target hematocrit of 40 to 50%. So this is in brief about the management of Rh negative pregnancy. And if you have given antenatal anti-D prophylaxis, you are supposed to give again even the postnatal prophylaxis. What is the postnatal anti-D dose? The anti-D dose is 300 microgram. That is 1500 international unit. How do you give? It is IM. It is sufficient to neutralize 30 ml of fetal blood and 15 ml of fetal RBCs. So these points they will ask in the viva. So these units you are not supposed to confuse. It should be perfect. Okay, this is in brief about fetal maternal hemorrhage, that is Rh negative pregnancies. Thank you so much.